Core Topic 1. Evidence and Review of Active Management of the Third Stage of Labour. Every year there are 14 million cases of excessive bleeding after delivery or postpartum hemorrhage that result in over 150,000 deaths annually. Aside from death, additional morbidity comes from maternal anemia, prolonged hospital stays, and the resulting financial burden to the family. The third stage of labour begins with the birth of the newborn and ends with the delivery of the placenta and its attached membranes. Once the baby is born, the muscles of the uterus contract, helping the placenta separate from the uterine wall. The amount of blood loss depends on how quickly this happens. If the uterus does not contract normally, the blood vessels at the placental site stay open and hemorrhage results. There are two approaches to the management of the third stage of labour. The physiologic approach is an expectant approach. No medications are given to help the uterus contract. The provider waits for signs of separation of the placenta, a gush of blood and lengthening of the cord, and then the placenta is delivered by gravity, assisted by maternal effort. The active management of the third stage of labour involves administration of a uterotonic drug within 1 minute after the birth of the baby, controlled cord traction during contractions, and uterine massage immediately after the delivery of the placenta. 2 large trials in the UK have consistently shown that the active rather than physiologic management reduces the length of the third stage of labour, the incidence of postpartum hemorrhage, and the need for blood transfusion. For every 12 women receiving active management, 1 postpartum hemorrhage is prevented. Core Topic 2. Causes and Prevention of Postpartum Hemorrhage. The most common cause of excessive bleeding in the first 24 hours after birth is uterine atony, or inadequate contraction of the uterus. Other causes include retained placenta and cervical, vaginal, or perineal lacerations arising from episiotomy or poorly controlled or instrumental deliveries. Uterine rupture and inversion and maternal clotting disorders are also causes, but are rare. Postpartum hemorrhage is unpredictable, so every woman is at risk. At all stages of pregnancy and delivery, steps can be taken to reduce the impact of postpartum hemorrhage. In the antenatal period, screen for and treat anemia. Plan for the birth, including a birth attendant skilled in the active management of the third stage of labour. Be prepared for the complications of delivery, including logistics of emergency transportation. During labour and the second stage, use a partograph to monitor and guide the management of labour, recognise and refer potential problems early, and prevent prolonged labour. Do not encourage the woman to push until the cervix is fully dilated. Consider episiotomy only in situations where indications for it are met, and assist the woman in the controlled delivery of the baby's head and shoulders. During the third stage of labour, provide all steps of active management: use of uterotonic drug within 1 minute of delivery, controlled cord traction, and uterine massage. In the immediate postpartum period, up to 6 hours after childbirth, check blood pressure and pulse, check for vaginal and perineal bleeding, and massage the uterus until firm every 15 minutes for the first 2 hours, 30 minutes for the next hour, and then hourly for 3 hours. Ask the woman to call for help if bleeding increases or her uterus gets soft, and if bleeding occurs, take action immediately. Core Topic 3. Uterotonic drugs. A uterotonic drug is a substance that stimulates uterine contractions or increases uterine tone by acting on the smooth muscle fibers of the uterus. There are several uterotonic drugs available, and the most commonly used is oxytocin. Oxytocin is produced naturally in the body by the posterior pituitary gland during later pregnancy, labour, and when a baby breastfeeds. In moderate doses, it produces slow, generalized contractions of the muscles of the uterus, with full relaxation between contractions. The dose of oxytocin for the active management of the third stage of labour is 10 units given intramuscularly or 5 units given slowly through an intravenous drip. It is available in a single-dose vial, multi-dose vials, and is also available as a Uniject device, which is a pre-filled, single-use device containing 10 units of oxytocin. Oxytocin acts within 2 to 3 minutes, has no known contraindications for postpartum use, and has minimal side effects. Although best kept refrigerated, it is relatively light and temperature stable. Oxytocin is recommended by the World Health Organization as the drug of choice for the active management of the 3rd stage of labor. Methogen and ergometrin are also uterotonic drugs. However, these cause tetanic or continuous contractions of the uterus, which may increase the risk of retained placenta. They act within 6 to 7 minutes when given intramuscularly, and the effect may last 2 to 4 hours. They increase blood pressure, and their use is contraindicated in women with elevated blood pressure, preeclampsia or eclampsia, and heart disease. Side effects also include nausea, vomiting, and headaches. Ergometrin is not light and temperature stable. It needs to be kept in the dark and kept cool. The cost of oxytocin and ergometrin is comparable. Syntometrin is a product containing a mixture of 0.5 ergometrin and 5 international units of oxytocin. It has the same side effects, light and heat instability, and contraindications as ergometrin. Misoprostol is a synthetic form of a prostaglandin found in the uterus. Given orally, it causes uterine contraction, acting within 6 minutes with a duration of action of 75 minutes. Shivering and elevated temperature are common side effects. The dose is 600 micrograms, given as 3 200 microgram tablets, orally, sublingually, or rectally. It is stable from light and temperature, but needs protecting from humidity. Never give oxytocin for at least 6 hours after misoprostol. As misoprostol's use is still not common, following local guidelines is recommended. Or topic 4, infection prevention. Infection prevention practices should follow 5 standard principles. Every person, client or staff is considered potentially infectious. Hand washing is the single most important practice for preventing cross-contamination. Wear gloves before touching anything wet, such as broken skin, mucous membranes, blood, or other body fluids, or handling anything soiled. Use other protective items, including apron or gown, if splashes or spills of any body fluids are expected. Follow safe work practices and guidelines for care with sharps, cleaning of instruments, and disposal of waste. To correctly wash your hands, wet your hands with running water and apply soap. Rub together all surfaces of the hands, including wrists, between the fingers, palm and back of the hands, and fingernails. Wash for 15 seconds. Rinse under a stream of running water. Dry hands in the air or using a clean cloth or paper towel. Always wash hands when arriving and leaving a health facility, before and examining a woman or baby, and after removing gloves. A gown or apron, gloves, mask and goggles, or face shield help protect you from splashes of contaminated fluid. Also consider your footwear, so feet are not at risk from splashes or accidents from sharp instruments. Single-use or disposable gloves should not be used more than 3 times. Do not use gloves with cracks, tears, or holes. Core topic 5, essential newborn care. Newborn deaths represent 40% of all deaths among children under the age of 5. Each year, 4 million babies die within 30 days of birth. 2/3 of neonatal deaths occur in the first week of life, and 2/3 of those deaths occur within the first 24 hours of life. All babies need basic care to ensure their survival and well-being. This basic care is called essential newborn care. Essential newborn care can be divided into the immediate care at birth, care during the first day or 24 hours, and care up to 28 days. The main purpose is to keep every baby healthy and is focused on helping the mother to meet the baby's basic needs: warmth, normal breathing, feeding, and infection prevention. Here we'll focus only on the immediate care at birth. It is important to prepare the environment, equipment, and supplies that are needed for the care of a newborn at birth. Prevent infection by washing your hands, ensuring equipment and supplies are clean, and wearing gloves and other clothing to protect yourself from splashes and spills. Be sure the birthing area is clean and well lit. Most importantly, the room should be warm, as newborns lose heat rapidly at birth. There are 7 key steps for immediate care at birth. Dry the baby, including the head, immediately using a clean, warm cloth. As you dry the baby, check to see if the baby is breathing, having trouble breathing, or not breathing at all. The tongue and lips should be pink, not grey or blue. If the baby is not breathing, or is breathing less than 30 breaths per minute, or is gasping, he needs resuscitation. Begin resuscitation immediately. 2 to 3 minutes after delivery, tie the cord securely in 2 places and cut the cord between the 2 ties using a sterile instrument. You may use a small piece of cloth or gauze to cover the part of the cord you're cutting so no blood splashes on you or others. The warmth of the mother passes easily to the baby and helps stabilize the baby's temperature. Put the baby on the mother's chest for skin-to-skin warmth. Cover the mother and baby together with a warm cloth or blanket. If everything is normal, do not separate the mother and baby for weighing or other routine procedures until feeding has started. Initiate feeding within the first hour of birth. For mothers who are HIV negative or who do not know their HIV status, encourage and support exclusive breastfeeding. For mothers who are HIV positive, initiate breastfeeding or replacement feeding per mother's informed choice and continue that form of feeding exclusively. Provide immediate prophylactic eye care. Teach the mother to check the baby's breathing, color, and warmth by feeling the baby's feet and the cord for bleeding. Discuss the danger signs with her. Tell her to call for help if she has concerns. Continue to monitor the baby each time you check the mother, every 15 minutes for the first 2 hours, 30 minutes for the next hour, and then hourly for 3 hours.